All right, guys. Hey, it's Wade. I wanted to re-record. I recorded this lecture once already, but didn't share my screen, so that was awesome. I am re-recording this. I'm going to move a little bit quickly because I've got to get my tuchus home for a family function. So I'm going to kind of move a little quicker through this. Didn't share this the first time, so let's try it again. Okay, so quality improvement, guys. Dr. Russell delivered this lecture to you guys on Monday. So for those of you that were there, that's awesome. I know that a handful of you were participating in interviews, right? So you were not able to be in class because those interviews overlap with class time. So let's go ahead and knock this out. So here's the deal, guys. So a lot of times as providers, right, we're taught to focus on individual problems, right? Diagnoses, treatment plans, and problem solve, because that's what we're trying to do as healthcare providers, right? But many times in our practice, we're gonna run across problems, right? That seem to present themselves over and over again, based on the structures that surround us. Okay, so obviously, healthcare systems exist, right? And those are combinations of providers, administrators, and the diagnostic and therapeutic options that are allowed, right, inside of those structures, along with the policies that exist within the systems that we work for. It's those components that make up the healthcare system. Okay, so each one of those smaller components, right, can represent a microsystem. And many microsystems have been known to make up a healthcare system, right? And so all healthcare systems, no matter how small or big they are, suffer from quality gaps. Okay, basically, which are essentially situations where perhaps we're not providing the best care, and or an inefficiency or a problem within the system compromises our ability to provide good care, and or potentially compromises the patient, right, in some way, shape, or form. Okay, so if we're trying to define characteristics of what makes care the best it can be, right, what makes the best and the most ideal care, right, the Institute of Medicine, now called the National Academies of Practice, published a report in 2009 called "Crossing the Quality Chasm." Okay, and in that report, they identified criteria that they have abbreviated the STEEP criteria, right? So there's more than one E, and these are not in order, but let's go ahead and go through them. So obviously, in order for care should be safe first and foremost, right? So we should avoid harm to patients from the care that we provide, right? It's care. It should the intention is for it to help them, obviously not to harm them. Okay, and obviously medical mistakes and errors fall into this category. Okay. The care should be effective, right? So we should provide services based on scientific knowledge, okay, i.e., evidence-based practice, right, to all who benefit, and refrain from using those things that are not useful and or not likely to benefit, right? So that's evidence-based practice right there. Use the best available evidence along with your experience and the patient's individual circumstances / presentation. Okay, care should be patient-centered, meaning that, right, we need to give the patient that shared role in explaining treatment options, and let them have a kind of a hand in deciding what they want to do with the guidance of the clinician, right? And then obviously timely, right? Obviously delays in care can be very, very costly for the patient, right? Delayed diagnoses, God forbid, in the case of cancer and other things, right, can be a big problem. Okay. So care should be efficient, right? We should avoid wasting equipment, supplies, ideas, and energy, right? So efficient care is very, very important, particularly in a clinic environment when we talk about throughput and things like that, right? And I think this goes without saying, guys, our care should be equitable, right? We need to work towards and do our absolute best, right, to provide care that does not vary in quality because of who we're seeing, right, on characteristics such as gender, ethnicity, geographic location, or socioeconomic status, right, and in things, And here's the thing, right? In areas where you know that this is going to be a problem, right? Where maybe you're working in an environment that's lower socioeconomic status, you may have to adjust the way that you care for patients and the way that you educate to achieve that aim, right? You may have to kind of go the extra mile and take the next step on how you explain things and on how you verbalize, treatment options and diagnoses to make sure that people understand, right? And that we are being very clear and that we're being helpful with our options and with what we're doing. Okay. All right. Identifying the gap. So if the STEEP criteria represent the ideal functioning of a healthcare system, right, then quality improvement involves finding a care gap in the quality of care. So we define the quality gap as the difference between expected level of care and the measured outcomes of a healthcare system. Okay, that can be cost, that can be any metric. You pick the metric, number of hospital admissions, number of deaths, right? Whatever it is. All right. Quality improvement itself is defined as the combined and unceasing efforts of everyone. Okay. Healthcare professionals, patients and their families, right? Researchers, payers, planners, educators, right? Everyone, right? To make changes that will lead to a better patient outcome, better performance of the system, right? And better professional development, i.e. education, right? So by delivering this lecture right now and training all of you in research, we are doing our part in quality improvement. So what does research have to do with quality improvement? Okay, very simply, any quality improvement project at its core is a research project, 1000%, right? This is a lot like a quasi-experimental and or observational study. But we're going to talk in a minute about how those differ, right? So generally speaking, with a QI project, a multidisciplinary team will identify variables and outcomes just like we do in any study, right? And so quite often the variable in this type of project is a disease or condition of interest, just like with the observational studies, right? Followed by an outcome, like our dependent variable, right? And or level of improvement that we want to try to achieve. Okay, so here's the deal. A QI project uses basically a subsequent reevaluation and implementation sequence called a plan, do, study, act cycle, or a PDSA cycle. Okay. And I know that Dr. Russell shared a video with you guys in class, and I will post that link as well. But what is PDSA, or plan, do, study, act? Okay. Here's the thing. With the quality improvement project, this cycle is continuous. It goes on and on and on, and it repeats itself, right? So obviously we're planning the project, right? Kind of identifying what we're going to do, identifying risk factors or problems that we want to try to solve, and how we plan to solve them. Okay. So we're going to plan the QI initiative, then we're going to do it. Okay. And then after doing it, we will study the outcome. What happened? Did it work or did it not work? Right? Did we achieve the goal that we set out to achieve? Did we meet our mark, right? As far as making that system-wide improvement, yes or no? Right? And so then we act by making adjustments to the plan, right? And implementing it again. Now, here's the key difference between a QI project and a traditional research study. The difference is this. With a research study, we have to be very meticulous in planning our methodologies because we only really have one shot. I can't look at a participant, right, in a traditional study and say, you know what, crap, I screwed up. We're gonna have to do this again. Sorry about that, right? But in a QI project, that's exactly what we do, right? We say, you know what, let's do this one time. Let's evaluate it out when it's done. Let's see, where we didn't meet outcomes, and let's go again, right? And so these projects are expected to be continuous and change based on whether or not we've met expected outcomes, right? And then we do them again and again and again and again, right? Until we achieve our goal or meet our aim, all right? So here's an example, okay? I'm using an athletic training-based example. And so a big problem that we've had and that we still have, right? This is not anything that's gone away. Generally speaking, concussions are generally underreported, right? There are 3.8 million concussions that occur every single year in the United States, right? However, only about 50% of those are ever seen by a healthcare provider, right? And so if we want to look at reasons or kind of study the problem as to why this occurs, right? we're gonna chat for just a second about a framework known as the socioecologic framework. Okay. So the socioecologic framework, or SEF, as it's abbreviated, consists of essentially 4 different domains. Okay, an intrapersonal domain, meaning within the person or within the patient. Interpersonal, meaning within the patient and a significant other or relationship, coach, parent, spouse, or other people, right? Between people, right? Community level, and then obviously safety and society and policy level. So obviously, with the interpersonal level, we are trying to obviously impact knowledge and attitudes, right? And perceived control, right? About what's going to happen if I report symptoms, right? And so obviously, when we talk about interpersonal relationships with concussion reporting, we have to worry about not only, patients or student athletes, we have to worry about their interactions with coaches, with parents, with friends, right? That may have other ideas or preconceived notions about concussion that may hinder or prevent them from reporting symptoms, right? And then there's obviously the community level, right? So maybe it's team culture. Maybe there are certain expectations within a culture or community that prevent patients from reporting those injuries. And perhaps also there is a lack of care. There's a lack of resources, so people don't know at what point, or when, or how to diagnose or treat these conditions because resources don't exist. Right, that can also be a problem. And then obviously at the society and policy level, this is an area where we've seen a ton of change, as now every single state in the U.S. has a concussion law on the books, right? So the state of Minnesota, obviously being a prime example, where coaches have to undergo a yearly training in regards to identification of concussion and the importance of removal from play. And then a student athlete has to be cleared, obviously, to return to play by an athletic trainer and/or physician. All right. So when we're trying to describe a problem that we want to address, right, in any TUI initiative, we can use a diagram that you see here called a fishbone diagram. Okay. So you can obviously see we've got the maybe the straight line in the middle, that's the spine. And then we have the little lines coming off at angles. Those are the pin bones of the fish. We have the head, and then we have these little rectangles, right? So maybe we've identified different areas, right, of the problem, and we've identified those by as people, policy, environmental factors, and materials. Okay, so maybe as you can see, people, right? How do we define the problem here, right? So coaches, teammates, and families may downplay or discourage reporting due to lack of knowledge or other factors. Right? We have policy, which is essentially policy promoting strict rest, and non-participation may influence on reporting. So what that means is the student athlete who knows that if they tell someone that they have a concussion, they're going to be out, right? They're not going to be able to play. They're not going to be able to return to the sport that they love. And so they just simply don't report it because they don't want to miss time, right? Environmental factors, right? So this is obviously other things like position, depth chart, status, years of experience, and or time of year. This is huge, right? So someone may be more apt to report a concussion, maybe in preseason and or early season, as opposed to NCAAs, right, and or playoffs, right? So we do find, particularly if that person has a significant role on the team or is a large contributor to their success, to the team's success, they may not want to report that injury for fear of not being able to play in a certain game, right? And then obviously, by and large, it could be that materials provided by the NCAA are largely not meeting expectations and or insufficient when it comes to targeting behaviors and trying to influence behavior change, right? So if we were to try to take all of those different areas and provide and bring them into focus with a single question, right? This is how we did it here. We said self-reporting of concussions is perceived as a non-desirable behavior in collegiate football athletes. We focus on football here in this example because when I was a collegiate athletic trainer, I was the director of sports medicine, and I was primarily responsible for an NCAA football program, right? As far as providing medical care, right? So that was just the example that's here, but this spans many, many different sports and types of examples. All right, so the quality improvement team, okay, as you can see here, and sorry about this is branding from a different school. This was one of my previous institutions. Um, the QI team is multifaceted, right? There are, in this case, it's, the sports medicine staff, the athletic trainers, the patients, right? The student athletes actually are part of the quality improvement team because they're the ones that are actually reporting the data, that are giving us the information, right? We have university administration and providing support, right, for production of materials, educational materials. And then we have the backing of our physicians and other providers as well that are working with us as a part of providing care. Okay, so obviously we've identified our problem and here, which we've already talked about, right? But the intervention is a mandatory preseason education with a quiz, right? So we quiz them after completing the educational intervention. And if I remember correctly, we actually said that you have to pass with a 90 or above, right? Or you have to actually retake the intervention and retake the quiz, right? And then we have an outcome. So we were looking at an outcome or an endpoint, essentially asking, right, does implementation of this program, right, result in increased concussion reporting? And believe it or not, it did, right? So we were thankful for that. Okay, so here's the other thing. Okay, the benefits of quality improvement also play a role. Excuse me, they play a role as well in solving healthcare disparities. So, an example of this: imagine that you are, doing a QI project in the setting of maybe a larger population. And ultimately, excuse me, that population has, maybe they are a lower socioeconomic status population. But if by doing your QI project, anyone who is identified with a certain injury or condition will receive care regardless of insurance coverage, regardless of their ability to pay for it, or, their ability to pay for it, and or, that type of a factor, right? What you have done by doing that is you have essentially, basically mitigated a barrier to access. You have created an additional access point, right, to healthcare, to the healthcare system that was not available to that individual previously, right? Because of obviously financial situation or insurance coverage, and or simply maybe another reason for lack of access, right? Maybe they're not an English speaker, and they can't find someone to provide care in a language that they can understand, right? So QI projects very often knock down barriers to access and provide people a window to care that they have never had before, right? So it's a really cool thing, right, to be able to do. So once again, as we've talked about, guys, if you can do a research study, and all of you guys have done a proposal this semester, if you can write a proposal, right, for a research project, you can do a QI initiative as well, right? So all of you, right, as you go throughout your careers, throughout school and throughout your careers, you're going to notice things over time that maybe lead to suboptimal care and or that create problems for yourselves as clinicians or even administratively, and also for your patients. But perhaps with your background in research and your knowledge, right? Now that you've obviously obtained in methodology and in how to study things and how to study and inform research questions, you can actually formulate your own QI project as well, right? So the cool thing about QI projects is that they harness a very human touch, right, to the application of research methods. And this is constantly applicable to any encounter or healthcare environment that you're in. No matter, and the problem can be a larger problem or something really, really small, right? It can be a crazy easy, and or small scale type of issue. But maybe even by addressing smaller scale problems over the course of time, you can move mountains, right, in healthcare by doing things like that. So I hope this has been helpful. If you have any questions about this type of a process, please let me know. But I am looking forward to class tomorrow. We're going to do some evaluations. We'll talk a little bit together, and I will see you guys then. Okay, take care, guys. See ya.